I'm not going to talk about the interior aspects of the brain. I'm going to talk about the exterior aspects of the brain. I'm going to talk about the venous drainage of the brain. So you all know when we talk about the brain, right? First we start off with something that looks like this. First, remember that this are what we call the what? Gyrus, right? And these are what we call the what? Sulci. Right here in what we call this, the cerebral longitudinal fissure that separates the cerebral hemisphere into two. We have a line that runs across from here and goes to meet another line here. This is what we call the what? Central sulcus. Everything in front of it, we call it what? Pre-central gyrus. And everything posterior to it, we call it the post-central gyrus. Now, which is sensory, which is motor? Which is sensory, which is motor? This here is the what? Sensory aspect, and this here is the motor aspect. Okay? Those are one of the things that we always want to be emphasis on. Now, we know that posterior to this is what we call the parietal occipital sulcus, which enables us to differentiate the parietal lobe from the occipital lobe. Also, what is this lobe in front? We call this the frontal lobe, and the lobe inferiorly temporal lobe. I know that this is cerebellum or cerebral hemisphere, and anterior to cerebral hemisphere is a pregnant lady we call the what? Pons, and the inferior region we call that the medulla oblongata. Now this here is just an overview of everything we expect. Now why did I start with this? Because we're going to be talking about the blood supply to this region. And when we're talking about the blood supply to this region, we're talking about what? Circle of Willis, right? So what two arteries make up the circle of Willis? What two arteries make up the circle of Willis? First, I have my vertebral arteries. They come together to form your what? Basilar artery. Basilar artery divides into two. But before it divides into two, it gives rise to this artery. It gives rise to this artery as well. Okay? And it gives rise to all these tiny branches. We call this the pontine branches because these branches are found around the pons. We have the superior cerebellar artery. We have what we call the anterior inferior cerebellar artery. And these two arteries that make up them is what we call the what? Vertebral artery. The basilar artery divides into what we call the posterior cerebral artery. Now I always want you guys to take notes. So between the posterior cerebral artery and the superior cerebral artery is my what? Oculomotor nerve. And we talk about this because of whenever we talk about aneurysms here or aneurysms here, it would always impact this. We're going to look at how it impacts this and what would that presentation be. Finally, from here, I have this artery that joins with this. We call that the what? Posterior communicating cerebral artery. And it communicates with what? Internal carotid artery. The internal carotid artery is going to divide into two. Middle cerebral artery and anterior cerebral artery. This is what we call the anterior cerebral artery. There's a communication in between both of them. We call that the anterior communicating cerebral artery, right? Now, one of the relevance of all of this is we talk about blood supply to this region. And when we're talking about blood supply to this region, we're talking about if there's an occlusion to the middle cerebral artery, what would it affect? If there's an occlusion to the anterior cerebral artery, what would be the effect? If there's an occlusion to the posterior cerebral artery, what would it affect? The cerebral arteries are pretty easy. It affects the cerebellum. What does the cerebellum have to do with anything? Balance, proprioception, that much it would affect. The posterior cerebral artery has to do with what? Vision, because it supplies the occipital region, which does vision. The middle cerebral artery has to do with what? The temporal lobe, and as well as parts of the parietal lobe as well. What part of the parietal lobe? You remember the homunculus that's found around the parietal lobe. What aspects of that do you think it would supply? So if my brain is like this, if this is my brain right here, and the homunculus is, my legs are here, my face is here, my middle cerebral artery comes through here. So it would affect parts of the head and neck. So that's one of the reasons why we lay emphasis on that blood supply. You use the blood supply to understand parts of the brain that are affected. You see us bring up questions about this when we talk about CVAs. Are we clear about CVAs as stroke or stroke-like incidences? Are we clear about this? So this here is the blood supply. Go back to your notes, look it up, go through it. Roshan.
I don't know if it's relevant, but the anterior spinal artery comes off the vertebrals, right?
Yes, it does. So the anterior spinal artery comes off the vertebral. The posterior arteries, spinal artery comes off the vertebral actually as well.
Oh no, I want to see this.
Yeah.
Thank you.
What's also relevant here, I'm going to use a line diagram to represent this, but I want you all to take notice of the location of all of these structures. Blood supply comes from where? All of these arteries, once arteries give oxygen, nutrients, you need to collect that blood supply. In other words, you need to have deoxygenated blood flowing out of the brain. How does that occur? It occurs via what we call the dural venous sinuses. You guys remember the dural venous sinuses? That means they're found within dural matter. That is very important. And why is it very important? Because those dural venous sinuses communicate with other veins as well, via what we call bridging veins. You've heard of the shaky baby syndrome. You've heard of subdural hematomas. Subdural hematomas are due to what? Rupture of the bridging vein. Sometimes they use the word emissary veins. Sometimes they use the word what else? What else they use? Is it branching veins or something like that? I can't remember. But what that means is that the connection, the fact that the brains go from the outside through the bone to connect with your sinuses. If you move someone around too much, you rupture that vein in between. Blood is going to leak in between your dural mater, hence the term subdural hematomas. Now let's get some of those veins, starting with the superior sagittal sinus, which drains into where? The superior sagittal sinus is found in what part of the dural sinuses? Your falx cerebri. It drains to what we call the confluence of sinuses. From the confluence of sinus, something else that drains confluence of sinuses. What we call the straight sinus. Straight sinus. Where is the straight sinus found? Within your tentorium cerebelli. Now take notice of this. This superior sagittal sinus is what all of the other tributaries drain into. So I have veins all across the brain. Those veins drain into this region and they drain into this. But this vein here doesn't start by itself. The first vein you have is found in the superior aspect of the falx cerebri. Another vein which is found on this falx cerebri, which is called the inferior sagittal sinus, comes together with what we call the great cerebral vein to become your straight sinus. This inferior sagittal sinus is found in my what? Falx cerebri as well. So the falx cerebri contains two veins, one above, one below. Both of them, the one below combines with great cerebral vein and goes into your tentorium cerebelli to become your straight sinus. The superior sagittal sinus and straight sinus meet together at the confluence of sinus with another additional vein, what we call the occipital sinus. The occipital sinus is found in what? In your falx cerebelli. The location of these veins is very important. Are we clear about this? From the confluence of sinuses, veins, blood will travel out on the lateral aspects of my tentorium cerebelli within what we call the what? Transverse sinus. Please, all of these veins that I'm making mention of, we are going to tag them for you in the lab as well. Transverse sinus. From the transverse sinus, it goes into what? Sigmoid sinus. From the sigmoid sinus, it's going to become what? Internal jugular vein. So what do I expect you to also understand? There's also what we call the cavernous sinus in here. And the cavernous sinus drains via two veins at the beginning and at the end of your sigmoid sinus. These two veins of dural venous sinus are known as the superior and inferior petrosal sinuses. Are we clear? This is the entire venous drainage. You're expected to know them. You're expected to know within what structure they're also found. You might want to draw your own diagram, look at the picture and understand it. Are we clear about this? That's all I'm doing about the brain and venous drainage. Now let's look at the structures coming off the brain and the venous drainage. So let's talk about my what? So whenever we talk about the head and neck, whenever I talk about the head and neck, I use the cranial nerves to describe the entire head and neck. And one of the first things I always look at is this. You guys are going to say cranial nerve 1, 2, 3. Don't do that. Always try to know the names of each of the cranial nerves. So I'm starting with, what's the first cranial nerve that you lay emphasis on? that you see, olfactory. I say olfactory, the nose is the most prominent thing on the face. Everybody always says that the first thing you look at is someone's eyes. Well, you're overlooking the nose. Olfactory nerve is the first cranial nerve. Olfactory nerve is found only within the nose because it enters in through the cribriform plate and it goes to synapse at the olfactory bulb, follows the olfactory tract into what we call the temporal lobe. Within the temporal lobe is what we call the amygdala complex. Now, we're not asking for all of that, but one of the things I try to do is I try to tell you a story so that you'll be able to remember that. Olfactory nerve pierces through what again? Cribriform plate of the ethmoid. Are we clear about that? When you have a fracture of the cribriform plate of the ethmoid, it's going to present as what? Inability to smell. When you have a fracture of the cribriform plate of the ethmoid, you are going to have CSF coming through what we call CSF rhinorrhea. Are we clear about this? All of that is a clinical condition we expect to see. The second cranial nerve is your what? Optic nerve. The optic nerve goes through your optic canal, which is found within the lesser and greater wing of the sphenoid. It goes through there with another structure. What structure is this? Ophthalmic artery, a branch of the internal carotid artery. Both of them go through the optic canal together. You have a fracture of this canal, you are going to have optic nerve blindness, as well as that ophthalmic artery would not be able to go through as well. Posterior to this, in other words, you've looked at the nose, you looked at the eye. Now the eye doesn't stand still in one direction, the eye moves around constantly. So we have nerves that enable the eye to move around, which means that we're dealing with our third cranial nerve, oculomotor, our fourth cranial nerve, trochlear, and our sixth cranial nerve. So why did I skip the fifth? I'm not skipping the fifth. The fifth does not have anything to do with eye movement. Rather, the fifth gives rise to a branch. The fifth cranial nerve, trigeminal, gives rise to a branch that innervates the mucosa, everything in the eye. In other words, carries a sensory innervation for the eye. As a result of it, that nerve is called the ophthalmic branch of trigeminal. So I have all 5 cranial nerves that are coming in together. They all go through the same foramen, superior orbital foramen. They all pass through the same sinus, cavernous sinus. That's one reason why all of this structure are found in the lateral aspect of the cavernous sinus, with my abducens nerve being the most medial structure. What did I say again? Abducens nerve is the most medial, which means that whenever you have a thrombosis and enlargement of the internal carotid artery, you are going to have damage to the abducens nerve. Abducens nerve does what? It innervates the lateral rectus, which enables me to look laterally, which means to abduct my eye. So that means that if my abducens nerve is damaged, you're going to have what? Adduction of the eye. Which brings me as well to the other forms of eye movement. Oculomotor nerve, we say, innervates all of the muscles of the eye, except what? Lateral rectus and superior oblique. Lateral rectus is innervated by the abducens nerve, the 6th cranial nerve. Superior oblique innervated by the 4th cranial nerve, trochlear nerve. Now that's not all about the oculomotor nerve, because oculomotor nerve also innervates the muscles within the eye. What muscle within the eye does it innervate? What muscle within the eye does it innervate? Now let me give you an example. Let me break this down for you. Oculomotor nerve does parasympathetic innervation. Parasympathetic innervation means that what? I need my eyes to close. What muscle helps me close the pupil around my eye? We call that muscle constrictor pupillae. So oculomotor nerve innervates your what? Constrictor pupillae. Constrictor pupillae takes part in a very important reflex, what we call the pupillary light reflex, which means if I shine my light into an eye, I would expect that eye to constrict. So that means that I have an afferent, and I have an efferent. The afferent part of this is what? Oculomotor, right? And the efferent part of this is, the afferent part of this is optic. Alright, optic. Optic carries the nerve, and the efferent part of this is what? Oculomotor. Now, here's the thing about the optic nerve. Because the optic nerve, this comes in, because I have this part coming into, this is the optic nerve, right? This is the optic nerve. This is the optic chiasm. And this is what we call the optic tract. Now, information from, we say that the visual light fields divide into what we call the temporal and the nasal fields of vision. Now, because light undergoes what we call a refraction, that means that light doesn't travel in a straight line. So the light that's coming in from here, from this side, when it gets here, it comes to this field of vision. This is what we call the nasal aspect of the retina. But the fibers that are being carried here are what we call what? Temporal fibers or temporal fields of vision. So this is one reason why if anything should affect this region where the fibers crosses, we say that it's going to bring about what? A bitemporal. Temporal. ME means what? Half. Anopia. Bitemporal hemianopia, which means the temporal fields of vision are gone. And just that half. That's what it is. So now the problem arises as well within when we're talking about the pupillary light reflex, right? The problem arises in pupillary light reflex when if I shine light into this eye, if light is coming into this eye, that means that it's not just this eye that's ought to respond, the other eye is ought to respond as well. So we call when the other eye responds, here I'm shining light into it, a consensual light reflex, which means this eye also has given consent to the light to come into it. So there's a consensual light reflex. So this is what occurs now. This gives rise to a lot of problems I would expect you to be able to understand. If my patient comes in, I've shown light into this eye. What do I expect to happen to this eye? Constrict, right? Now because light is traveling to this eye as well, what do I expect to happen to this eye as well? This eye is also going to constrict. Do you understand? That is normal. You shine light into this eye will constrict, this eye will constrict. The same thing happens for this eye as well. Are we all clear about that? So that means that if I shine light into this eye, and this eye doesn't constrict, where's my problem? Where's the problem? I shine light to this eye doesn't constrict. Where's my problem? It could be either one of two things. It could be the optic nerve is not working, or the oculomotor nerve is not working. Now, how do I differentiate it? If my optic nerve is working, it's going to carry light towards this side. And what would I expect to happen here? It's going to constrict. So even if I shine light to this eye and this oculomotor nerve and your westbound nucleus is not working, this should work. Are we clear about that? But if I did shine light into this eye, this didn't constrict, this didn't constrict. That says my what? My optic nerve is not working for that eye. Are we clear about this? The same thing, so if I shine light into this eye, and this eye constricted, and this eye did not constrict, where's the problem? This eye did constrict, but this one did not constrict. Where's the problem? What nerve is damaged? My oculomotor nerve. Because I'm certain that my optic nerve is working because it's carried it down to here. It could be that you have a problem with chiasm, yes, but I'm not asking for that now. But definitely this is not working. Now, to be certain whether this eye is working, when I shine my light to this eye does not constrict. That is definitely telling me that my Edinger-Westphal nucleus or my oculomotor nerve is not working for the left eye. Is that confusing or is it clear enough? You have to understand the concepts. And you have to sit down yourself and understand this. It's not just my explaining it that's going to do it for you. You have to know that, okay, light comes in here, this will constrict. Light comes in here, because it's traveling in this direction, this will constrict as well. If there's a problem and this is not constricting, it could be one of two things. My optic nerve or my oculomotor nerve is not working. But how do I know my optic nerve is working? Because when it comes to this side, my optic nerve, my oculomotor nerve is constricting. That means my optic nerve is working. So that means that what I have is a problem with my oculomotor nerve here. If it's the reverse, you have to put everything together. You have to use all of the facts to answer questions. Are we clear about this? This is a major thing that you need to know and a major thing that you need to undergo. So we looked at 3, 4, 5, and 6. Now this here is one of the most important factors, or one of the most important reflexes that relate to your optic nerve and your oculomotor. It's going to come up on your exam. You should know it. If you don't know it, well, you're doing yourself a disservice. All right, now be very precise about it. There are places where you could have a lesion for those 4 nerves. In other words, oculomotor nerve, trochlear, abducens, and ophthalmic. Places where you could have a lesion, superior orbital fissure, cavernous sinus. Those are the places where you could have lesions for them. Take notice of this. Let's move on from here. The next nerve is what? So let's look at the maxillary mandibular branches. We've already spoken about ophthalmic. Take notice of the fact that your ophthalmic nerve is a sensory nerve. Your maxillary nerve is a sensory nerve. Your mandibular is a sensory nerve as well as a motor nerve. Everything from the vertex down to here, every single aspect of that region is innervated by your ophthalmic branch. Everything from below the eye to the superior aspect of the lip, maxillary. Everything below that region, mandibular. That means the sensory innervation for all of that region is carried by the trigeminal. Now, the only part about it is that the mandibular branch now gives rise to muscular innervation. That means that all of the muscles that you learned today, muscular mastication, nerve to the mylohyoid, and anterobellar digastric, as well as your tensor villi and tensor tympani.
Is part of the nose involved in the
yes.
P1 as well?
Ophthalmic innervates. You remember ophthalmic gives rise to, some of those branches. I don't like going to all of those branches of ophthalmic, maxillary, and mandibular. You should be able to understand mandibular. You should be able to understand this divides into what we call NFL. Nasociliary. Why? Nasociliary has to do with what? The nose and the ciliary aspect. This ciliary component is the part that goes to your ciliary ganglion. Remember that ciliary ganglion? This is my ciliary ganglion, right? And it has three things that come into it. 1, 2, 3. When I say 1, 2, 3, sensory, parasympathetic, and sympathetic. You all know that the sympathetic innervation of the entire head and neck comes from where? From your cervical sympathetic ganglion. Your parasympathetic in this region to the eye comes from what nerve? What nerve? What nerve gives parasympathetic to the eye? Oculomotor. Come on, guys. What do you think the oculomotor nerve is there for? That's why I said to you, oculomotor for the eye. Sensory innervation in this part to come from where? Nasal. This is why we say nasal ciliary. What do you think that ciliary is doing there? It's not just standing there saying hi, ciliary. No. Ciliary, nasal ciliary. So it gives rise to that ciliary ganglion and it invades the skin, overlying the nose, up to the tip of the nose. Very important. Lacrimal goes to where? You know where lacrimal goes to the lacrimal gland. Special innervation to that region. Frontal, you already are aware that divides into supraorbital and supratrochlear branches. Maxillary gives rise to everything. When I say everything, that means my dentition, my sinuses, they're all innervated by a maxillary nerve. Alright? This also, ophthalmic also gives rise to some of the frontal sinuses in that region. But when it comes to things like maxillary sinus, ethmoidal sinus, all of that's by maxillary nerve. Superior alveolar branches, alright, pterygopalatine branches, zygomatic branches. There's a whole list of branches there. I try not to memorize it. I don't want you guys trying to memorize it. Mandibular, you guys know all the branches of mandibular, right? You remember them. Auriculotemporal, lingual, buccal branches, inferior alveolar, nerves to the mylohyoid. Those are all the branches. Now, there's also something that's common for all these nerves. All of these nerves, they carry. All of these nerves, they do what? They carry what? Post-ganglionic parasympathetic. And I want you to go through all of that. Take notice of them. The only exception that doesn't really carry post-ganglionic are the I'm not going to say short ciliary. Actually, short ciliary does. Short ciliary. In fact, the only exception is your lingular nerve. You remember lingular? Guys, this is the lingular nerve. This nerve joins it. What nerve is this? Chordae tympani. And the synapses where? Submandibular ganglion. So everything that's carried before was preganglionic fiber. That's the only exception. But every other one carries what? Postganglionic sympathetic. And when I say postganglionic sympathetic, think about those nerves or those ganglions that you know about. I'm talking about OT ganglion. I'm talking about what else? Alright, what other one? Pterygopalatine ganglion. Come on. You can't forget any of these things because it's really important. Alright, moving on. Facial nerve. You guys like that nerve? How are we doing so far? Facial nerve. Let's go into the facial nerve and your vestibulocochlear because we've done everything now up to the 6th cranial nerve. Facial nerve starts right about here, what we call the IAM, internal acoustic meatus. It comes in, and when it's coming in, it's coming in with who? It's coming with this very nice guy. You know what this nice guy is? This is your vestibulocochlear nerve. Your vestibulocochlear nerve innervates your vestibular system and your cochlear system. And vestibulocochlear. The vestibular system is all about balance. The cochlear system is all about what? Hearing. Take notes of that. Your facial nerve comes in, is going to bend. That bend is known as a what? Geniculate ganglion. When it bends, it gives rise to what we call the what? Greater petrosal nerve. Once it bends, it comes all the way downwards. In the end, it gives rise to two branches: chordae tympani and nerve to the stapedius. When it comes out of the stylomastoid foramen, it gives rise to the zebra beat my cookie. Temporal, zygomatic, buccal, mandibular, cervical, and posterior auricular. Let's go back to the greater petrosal part. Greater petrosal synapses at the pterygopalatine ganglion. However, before it does that, another nerve comes from the internal carotid artery. This nerve is wrapped around what we call the what? We call this what? Deep petrosal. This is the only sympathetic nerve that is named. That is the only sympathetic nerve that is named. Deep petrosal. Your deep petrosal nerve comes together with the greater petrosal, and they both become what? What do these guys become? Nerve to pterygoid canal. They both become nerve. Once they combine, they become nerve to pterygoid canal. Now remember that deep petrosal is what? Is it preganglionic or postganglionic? Postganglionic. Is greater petrosal preganglionic or postganglionic? Preganglionic, because it's going to synapse at my where? At my pterygopalatine ganglion. Once it synapses at my pterygopalatine ganglion, it's now going to be carried by my zygomatic branch of maxillary nerve, zygomatic branch, which is now carried to my lacrimal nerve, which is carried to my where? My lacrimal gland. That zygomatic branch will carry the rest of it to my nose and my hard palate. Nose and hard palate. Nose and hard palates. Okay? Now, remember this. My greater petrosal is preganglionic. My zygomatic branch is carrying the post. Lacrimal is also carrying the post to your lacrimal gland. So when you start making tears, guess what's going to happen to your nose? Greater petrosal is going to say to your nose as well, you need to start producing mucus. And when you start crying, your nose is going to start running. And you know also when you're producing tears, something else goes from the nasal lacrimal duct. It carries it all the way to the inferior meatus. So when you're crying, guess what? All the tears is coming out through your nose and your eyes as well. Okay? Lastly, your chordae tympani, do I need to go into that? You all know that when it synapses with the submandibular gland and gives rise to taste in the anterior 2/3, right? Now you should know about lesions to this entire picture, because this entire picture is all about lesions. The first thing about it is that if I have a lesion here, it presents as what? You guys say Bell's palsy. What is Bell's palsy?
Facial paralysis.
What is facial? What do you see on facial paralysis? All right, drooping of one side of the mouth, drooping of the angle of the mouth, inability to close the eye. Now that brings me also to another question. Have you heard of the blink reflex? Blink reflex is what? When I touch the eye, what carries the afferent sensation for the eye? What carries the afferent sensation for the eye? I'll take nasociliary, which tells you what? Ophthalmic branch of mandibular, of the trigeminal. That's afferent sensation. Now, what enables you to close the eye? Facial. So what's the efferent for blink reflex? Facial. I'll be clear about this. Because when you come to the exam, you're going to see trigeminal, you're going to see all of these parts in it. Alright, so that's blink reflex. Now, come back here. Your inability to blink is also another aspect of facial nerve damage. Bell's palsy, all of these muscles do not work. You have another lesion in the facial canal. That means none of this muscle is working, as well as I can't taste in the anterior 2/3, as well as I'm having hyperacusis because my nerve to the stapedius. This is nerve to stapedius. That's also damaged as well. Alright, I have a lesion up here, the greater petrosal nerve. What's going to happen as well? I have Bell's palsy, I have loss of taste, hyperacusis, and guess what? My eyes are now dry because I'm not producing tears again. Why your eyes dry? Why does dryness of the eye affect you? Because the only way your cornea gets oxygen and glucose is when you produce tears. So you see, crying is actually a good thing. It actually helps you see better when you cry. I'm joking. Don't cry. Alright. So you have dryness of the eye, dryness of the palate. The last part is right here. If I have a lesion in the internal acoustic meatus, I'm going to have all of these problems, and I also would have what? Deafness. Alright, now the problem is this. Always remember this. We pick the lesion. So you're not going to get all of this. You're not going to get, so what we say is, patient has drooping of the mouth. Patient has dryness of the hard palate. Where's the lesion? Right here. At the genicular ganglia. Or they'll say patient has drooping of the mouth and patient has deafness. We don't pick everything together. Are we clear about this? Alright. So that's for the vestibulocochlear nerve as well as the facial nerve. Finally, the last nerve that you have to deal with is what? The last couple of nerves. I'm going to deal with all of them together. Alright. The first one is what? Glossopharyngeal. Glossopharyngeal, we already know, innervates only one muscle. What does it innervate? Stylopharyngeus. But glossopharyngeal also gives rise to a very important thing. It gives rise to what we call a tympanic branch, which goes into your tympanic plexus, which gives rise to a lesser petrosal nerve. That lesser petrosal nerve synapses at my where? Otic ganglion, where it's carried by my auriculotemporal to my where? Parotid gland. Alright? Now, lesser petrosal goes through a foramen. What foramen does lesser petrosal go through? Have you heard of this? Mandibular nerve plus accessory meningeal artery plus lesser petrosal and the emissary vein all go through a foramen ovale. You take the first letter of all of them and it spells what? M-A-L-E, ovale. M-A-L-E is not ovale, guys. M-A-L-E is what? Male. Alright, these are all the things that go to your foramen ovale. So if you have a fracture of the foramen ovale, it's going to affect all of these things. Take notes of that. What else I want to give rise to over this? So when you're over here and you have damage to your postganglionic fibers in that region, those postganglionic fibers are not following that again. They will follow this other nerve, which is coming in here as well. Those postganglionic fibers follow this structure, and they just don't stop here. They will go all the way to the skin. Okay? They'll go all the way to the skin. This is what we call what? Fraze syndrome. Are we clear about this? Fraze syndrome. Alright. Lastly, my vagus nerve. My vagus nerve innervates what? I'm just going to highlight the branches that the vagus nerve innervates. Vagus nerve innervates what? It gives rise to two branches. Superior laryngeal and recurrent laryngeal nerve. Superior laryngeal nerve divides into external and internal branches. Okay? So right, superior and the external branch supplies what? Thyroid, while the inferior supplies the mucosa above the vocal cords. The recurrent laryngeal becomes the inferior laryngeal when it gets to the larynx. When this gets to the larynx, it becomes the what? It becomes the inferior laryngeal. Now remember, the inferior laryngeal nerve innervates all of the intrinsic muscles of the larynx. That means my oblique arytenoid muscles, transverse arytenoid muscles, lateral arytenoid muscles, vocalis muscle. Have you heard of vocalis muscles? Even if you haven't heard about it, as long as you hear it's in the larynx, as long as you hear arytenoid, cricoid attached to it, you know that it's innervated by the larynx. The only one that is not is what? Cricothyroid. Are we clear about this? So it's very important you know what these muscles do as well. The only muscle that helps you do anything in the larynx except adduction is what? Posterior cricoarytenoid, which does what? Abduction. Please, this is clear enough. Remember that with your inferior laryngeal, internal laryngeal nerve, there is an artery which follows it in between the what? Thyrohyoid membrane. Please remember that. Okay? Alright. Vagus nerve also gives rise to branches from the inferior laryngeal, branches that go into your what? Pharyngeal plexus, pharyngeal mucosa, which innervates the entire pharynx. Roshan, you were going to say?
I'm not sure what the palatoglossus.
Palatoglossus is going to be coming from the pharyngeal plexus as well, because that's right about. Remember, it's palate.
Yeah.
Anything that has to be palate, that is all pharynx. Okay, that's really the soft palate, because you don't have anything attached to the hard palate. All right. Okay. Any other questions? Okay. Remember glossopharyngeal, vagus, as well as the spinal accessory. Now remember, spinal accessory starts in your foramen magnum and it goes back through to go through your jugular foramen. Spinal accessory only innervates two muscles. You remember that? Sternocleidomastoid and trapezius. Good. They all go through the jugular foramen. All three nerves go through your jugular foramen, which your internal jugular vein. The last nerve is what? Hypoglossal. Hypoglossal innervates all of the intrinsic and extrinsic muscles except what muscle? Palatoglossus. Now remember this, whenever you have hypoglossal nerve damage, the reason why you see genioglossus acting different is because genioglossus, when it comes out, originates from the genu of the mandible. This is the bend. From here, it pushes the tongue out in the opposite direction. So when I have two genioglossus, it helps me maintain the tongue in a straight line. But when I have only one genioglossus, it's going to push the tongue to the affected side. Are we clear about this? Two hypoglossal nerves. So this hypoglossal, genioglossus rather, pushes the tongue in this direction. This one does in this direction to help me maintain my tongue in a straight line. This is gone. It's going to go to the affected side. So when they say to you that a patient comes in, the tongue is deviated to the right. What side is the lesion? Right, which one? Hypoglossal nerve. Now take notice that this is what we call a lower motor neuron lesion. When you get into neuro, you're going to hear about an upper motor neuron lesion. That is all, folks, that I'm talking to you guys about. All 12 cranial nerves, use that to look at everything in the head and neck. Do I have any questions? Do I have any questions? No questions. I'll see you guys tomorrow once again.